It's a pleasure to be here with you today from the Indian Health Service. My name is Ben Smith. I'm the Deputy Director for Intergovernmental Affairs, as was mentioned, and I'm also a member of the Navajo Nation. Our story in looking at tribal health policy in rural settings is very unique to me. I grew up on the Navajo Reservation in a very rural and remote area, but I'm also a second generation federal employee within the Indian Health Service. My father was a physician at the Indian Health Service. And so growing up, I had that opportunity of watching federal services provided to American Indians and Alaska Natives from that perspective. And now here in my policy role in federal government, I actually get to see things play out. So part of my presentation today, I would like to take you back in history and provide a little bit of information about the Indian Health Service and why it's so important and how it plays into the conversations of health policy development for American Indians and Alaska Natives. The Indian Health Service is committed to providing quality health care consistent with our statutory authorities and our government-to-government relationship with American Indians and Alaska Natives. As you can see on this slide, we provide comprehensive health services to 2.6 million American Indians, Alaska Natives, who are members of 574 federally recognized tribes. But how did we get to this point? Often when you're speaking about American Indians, Alaska Natives, the concept of treaties come up. And during the 18th and 19th centuries, when the US government was entering into treaties with American Indians and Alaska Natives, in exchange of land for education or healthcare or other sorts of services, a relationship was formed. But quickly after that relationship occurred, administration needed to come in, policies needed to be set on how to manage and work this partnership with American Indians, Alaska Natives. And to many that might find it quite surprising, in the 1800s, the administration of Indian Affairs was actually located in the U.S. Department of War. Now, this surprises a lot of people when you think about government-to-government relationships, but then looking at the strategies and policies of the time in responding to the healthcare needs of American Indians and Alaska Natives. As the United States was expanding westward, a lot of the healthcare services that you would find were surrounding military forts where episodic care would be provided. It wasn't until 1849 where there was a transfer from military oversight to civilian oversight when the Department of War transferred oversight and administration of Indian health to the Bureau of Indian Affairs, which is located in the Department of the Interior. And soon after that, turn of the century, in 1911, the first appropriated dollars came forward from Congress in the amount of $40,000. That equates to about $1 million today to address the American Indian and Alaska Native healthcare concerns. One key component or milestone in the legislative history and really sets forth appropriations to provide for the care of American Indians and Alaska Natives occurred finally in 1926 with the enactment of the Snyder Act. And really, it's this act that the Indian Health Service works off of today, in addition to other statutory milestones that will occur throughout history. One note I do want to make everybody aware of is that another important transfer occurred in 1955 when the Indian Health Service was formally established by law through the Transfer Act. Through this act, those buildings, facilities that were operated by the Bureau of Indian Affairs were transferred over to what we know as now the Department of Health and Human Services. And so when you think about the facility structure, where a lot of the centers were either schools or health centers that were attached to schools, that also plays into the history. About that time, the Committee on Appropriations of the House of Representatives directed the United States Public Health Service to take a comprehensive survey of the status of Indian health in general. And they established a survey team that would conduct extensive survey of Indian health over that time. And the results were immediately transferred back to Congress. And some of their findings and conclusions from this report, which was published in 1957 and is commonly referred to as the Gold Book because it had a gold cover to it, they found that, one, a substantial federal Indian health program is required, and that community resources should be developed in cooperation with the American Indian Alaska Native communities and done on a reservation by reservation basis. Thirdly, federal Indian health programs should be planned in each community and services made available to Indians under state and local programs. And finally, the effort should be made to recognize the obligations and responsibilities to Indian residents on a non-discriminatory basis from the state and local communities. Fast forwarding to today, that means a lot. When you have 574 federally recognized tribes with a government-to-government relationship, trying to develop one policy across the board that's going to fit everything is not an easy task at hand. And so other key legislative efforts really generated from this report. As you can see, promoting healthcare isn't just about providing clinical services. And from this report, Congress enacted the Indian Healthcare Improvement Act, which really set the basis for water and sanitation and to establish and install water issues. I think it's no surprise to anybody who is opening up a newspaper today or hearing the headline news of the challenges of just access to basic water in some of the American Indian Alaska Native communities. So this continues to be a challenge today, but environmental health and construction of hospitals started entering into the scene from this authority. And most importantly, I like to point out in the 1970s, when American Indian Alaska Native federal policy made a dramatic shift. So throughout most of the 1900s, well, advances were being made in terms of research on the situation. The federal policy at the time was one of termination. And by termination, I mean that really took a assimilation approach in trying to bring rural communities into urban health centers. And this is important as we contemplate tribal health policy moving forward. So on one hand, you have a government-to-government political relationship with each of the federally recognized American Indian Alaska Native tribes or tribal organizations. But at the same time, through these prior federal policies of relocation and assimilation, you now have a large population of American Indians, Alaska Natives that reside in urban centers. And their care now becomes a critical question in terms of equity and helping to bridge health disparity gaps for all American Indians and Alaska Natives. But in the 70s, this dramatic policy shift from one of termination to self-determination that was announced by President Nixon resulted in a key update to the Indian Healthcare Improvement Act, which expanded authorities for the types of federal services that Indian Health Service or the Department of Health and Human Services could provide, but two, a separate act, the Indian Self-Determination and Education Assistance Act, introduced a new renewed relationship that's based on the government-to-government relationship that the U.S. government has with each individual tribe. And with this brought about a new contracting mechanism. It's not a contract that's regulated by the federal acquisition regulations. It's not a contract that's operated under the rules and regulations of grants or cooperative agreements, but is truly a unique contracting mechanism that allows for the transfer of programs, service, functions, and activities that the federal government would otherwise provide directly to American Indians and Alaska Natives. And this is reflective in our system today. So we have three mechanisms in which American Indians and Alaska Natives can choose to receive their services. That could happen directly from the federal government, or a tribe or tribal organization could choose to exercise self-determination or self-governance authority under the Indian Self-Determination Education Assistance Act to contract those healthcare programs from the government and operate them tribally at the local level. This picture that you see on the screen of the Norton Sound Health Corporation Hospital is one that is operated and managed in Alaska by the Alaska Natives. And some of the benefits that come with that is that they're able to exercise additional flexibilities to redesign programs or retarget funds to meet the healthcare needs within that local community. Within the context of rural health, there's another item that I would like to touch on that occurred in 1965 and really gained momentum and speed as the Indian Self-Determination Education Assistance Act came about in 1975, and that relates to the Contract Health Representative Program. I know yesterday we were talking about community health workers, but the first time Congress established this program to bridge the existing gap between patients in the community who needed care and health clinics and hospitals that can provide that care. And by 1968, well, this is prior to the Indian Self-Determination Education Assistance Act, this became the first formal assumption of a program by an Indian tribe of an IHS-supported program. And this really is rural health at the basis in terms of the community members responding to the healthcare needs, helping to translate in their own language in a culturally appropriate and acceptable way to provide healthcare. As we move through our system, I point to this slide because it shows the facility infrastructure that plays out throughout the country. As you can see, there's a diverse range of the various types of healthcare facilities, ranging from hospitals to healthcare centers. In Alaska, there's Alaska Village Clinics. There's over 200 Alaska Native villages that are federally recognized in the state of Alaska. Population ranges, some can be very small. So these village clinics are very important. We have healthcare stations as well as centers that link to school health institutions. And then we also have authority to run youth regional treatment centers. And as you can see, by the split of those hospitals that are federally operated, as indicated by the Indian Health Service, you can see the number of tribal health programs. And by tribal health program, that means a tribe or tribal organization is operating that facility pursuant to the Indian Self-Determination Education Assistance Act. And it's interesting as you see the smaller facilities where the local decisions are being made that really play into the health objectives and policy setting at a local level within a tribal government. In addition to these facilities, circling back to the large population of American Indians and Alaska Natives that reside in urban settings, we also contract with nonprofit organizations, but also non-governmental, that are urban Indian organizations. We have 41 of those throughout the country. And within the Indian Healthcare Improvement Act, there's specific and unique authority for Indian Health Service to contract these. This slide provides a geographical representation of where the facilities are located throughout the country. I certainly invite you to visit our Indian Health Service website to view more on each of the locations. We have a great map and a resource for finding healthcare, which provides insight into the types of programs that are offered at any of our facilities. Now, the challenges are great. I think this is one area where Indian Health Service, tribal governments really find alignment with the rest of our counterparts in rural America. In particular, some of the challenges around life expectancy. An American Indian or Alaska Native that's born today has a life expectancy that is 5.5 years less than the US all races population. In terms of level of need funding, there's a number of materials that our partner organizations, such as the National Congress of American Indians or the National Indian Health Board tracks, that compares per capita expenditures, and certainly Indian Health Service falls at on the lower side of the scale. But one item in particular that Indian Health Service compares, we use what we call our Federal Disparity Index. And this is a comparison tool against mainstream health insurance to IHS funding for medical services. And what we find through this index is that the level of need funded is 48.6%. So less than half of the total need is what Congress appropriates each year for Indian Health Service to carry out through its statutory authorities. Recruitment, retention, as many of you, the challenges of hiring and remote location, in particular for the federal government, we have challenges even with our federal partners in parity of leave, salary, and not to mention everybody has experienced at least one time a hiring freeze. Our facilities and equipment, one, circling back to the fact that the main facilities were transferred from the Department of Interior. They are outdated. We have an aging facilities issue on our hand, but also equipment in hospitals, clinics, and our service units continues to pose a challenge. Even when you do have the opportunity to hire or onboard recent clinicians who just wrapped up many years of training and education, the equipment that they may be used to working off of is not reflective with the outdated equipment that is still utilized in some of our facilities. So bridging that gap is certainly important. And then finally, the health information technology and infrastructure. We are working towards electronic health record modernization, but ensuring security in this day and age, along with the infrastructure that's available in rural sites, continues to pose many challenges across the board. The final policy note that I do want to end on is that while Congress has made efforts very clear and underscored the federal policy as it relates to health, and that's specifically defined in the Indian Healthcare Improvement Act, it covers a number of topics. One, it ensures the highest possible health status for American Indians and Alaska Natives is set forth as a goal, and that's benchmarked or tied to the Healthy People objectives. We know that we've been working on those throughout government this past year to update. But as you look at some of the objectives that are being set, and tribes certainly fall into this category, is how is the rural component included into those objectives moving forward, certainly as it relates to the data that corresponds to those objectives. But third, we certainly ensure to maximize Indian participation through a new form of communication that's actually defined in law. And this is through tribal consultation and conferring with urban Indian organizations. So as we set policies in federal government, we want to ensure that we're inclusive of our tribal and urban partners. But finally, the policy sets forth objectives for health professionals, working in a government-to-government relationship, and finally, to provide the funding necessary for facilities operated both by the Indian Health Service and by tribes. And as tribes set their policies moving forward, it's important that we underscore our government's commitment to providing access to healthcare as established by those treaties and working within the bounds and scope of the laws that set forth our authorities. And with that, I will end my remarks and I'm going to turn it over to Kate. Thank you.